to the Robson's classification performed at Urban Health Center, Chitkupi Hospital, Hubballi. My guide is Dr. Rachana Ganti. Cesarean section is the most common life-saving obstetric surgery used in the cases where spontaneous vaginal delivery is not possible or contraindicated, and to avoid the maternal and perinatal mortality and morbidity. Worldwide, cesarean section has increased in last few decades. WHO has endorsed Robson's classification as a global standard tool for monitoring of cesarean section, and it is also called as Robson's 10th group classification system that classifies cesarean section in the 10 group according to the different categories of pregnancies. Group 1 contains the nulliparous, single, cephalic, third pregnancy with a spontaneous labor. Group 2 includes nulliparous, single, cephalic, term-induced labor or a planned cesarean section. Group 5 includes multipara with uterine skull, single, cephalic with a term. Group 6 includes nulliparous, single with breech presentation. Group 7 includes multiparous, single breech presentation including previous section. Group 8 includes multiple pregnancy. Group 9 includes single abnormal lie including previous scar. Group 10 includes single cephalic preterm including previous scar. The main objective of this study is to identify and analyze the most common indications for LSCS in urban health center. The materials and methods used in this study data was collected retrospectively from the paturation and the OT register of the people. Out of 668 women who underwent delivery, 571 underwent vaginal delivery and 97 underwent lower segment cesarean section in Chitkupi Hospital, Hubballi, Karnataka from Jan 2024 to June 2024. Data is so collected were further classified according to the Robson's classification and the results have been tabulated. The overall cesarean section rate during this study was 14.52% out of 97 LSCS, 37 were emergency LSCS and 60 were elective LSCS. As shown in the tabulation 1, most common indications for LSCS done under the emergency situation was fetal distress followed by the scar tenderness in previous LSCS. Most of the women, that is 43 women, who underwent LSCS in the age group of 20 to 25 years in Chitkupi Hospital, Hubballi, as shown in the tabulated 2. According to the Robson's classification, most common indications for LSCS which will be done in our hospital is 51.51% that comprised of previous LSCS that comes under the group 5, 22.70% comprised of nulliparous, cephalic, not in spontaneous labor that comes under group 2, 16.4% comprised of nulliparous, cephalic with in spontaneous labor that comes under group 1, 6.19% comprised of multiparous not in spontaneous labor that comes under group 4, 3.09% comprised of nulliparous with single breech presentation that comes under group 6. Cesarean section is a necessary intervention to decrease maternal and neonatal mortality and morbidity. It is also one of the best indicators for the quality of maternal health services. World Health Organization has endorsed that cesarean section rate is less than 15% to balance the risk and benefits of the cesarean section. According to the WHO, the interpretation of the Robson's classification report table requires the assessment of 3 main domains. First one is data quality and the type of obstetric population and the cesarean section rates. In this study, we implemented the Robson's classification system and assessed the proportion of each group in the obstetric population and contribution of cesarean section in the each group to the overall cesarean section rate and the cesarean section rate within the each group. In the present study, Group 5, Group 2, Group 1 turned out to be the most prevalent groups accounting for 51.51%, 22.57%, 16.4% cases respectively, which will be equal to our findings from Credit AI in another local response research observed that Group 1, Group 3, Group 3 to be the most prevalent accounting for 26.7%, 22.2%, 15.8% cases respectively. The results from the Robson's template classification system serve as a foundation with the conclusion, offering a clarity on who undergoes cesarean section but not
addressing the one behind its occurrence. Key factor like indications, method, and parameter outcomes are excluded, limiting the depth of conclusion that can be drawn from the study. Yeah, the most common indication was found to be the previous LSCS. This study provides the valuable insight into the most common indications for while ensuring the maternal and fetal safety. These are my references, and thank you for giving me this opportunity. Thank you.
Hello? Yeah, what is the percentage of cesarean section which happens in your hospital?
Percentage?
Yeah.
Total 14.52%. It is according to the WHO criteria that should be less than 50% in the hospital to balance the risks and benefits of the cesarean section. It is mainly in our hospital.
Okay. What is the take-home message of your study?
We shouldn't do unnecessary LSCS, especially in the primary ladder. We have to take antenatal care about that. Unnecessary LSCS should be avoided.
What was your objective in doing this study?
To know the commonest indication of LSCS which will be done in our hospital, ma'am.
Ideally in South India or in your place, what is the incidence of how many cesareans they do? This was done in some rural health setup, right? You are studying in KLE?
Yes.
So in KLE, what is the incidence? I mean, what is the percentage of cesareans?
Totally, actually, during the study period, 668 women underwent the delivery. Out of that, 571 underwent a normal delivery and 97 underwent LSCS. The percentage will be the 14.52%, ma'am.
That was in a rural health center.
Yes, ma'am.
You are studying in KLE.
Yes, ma'am.
In your hospital, what is the percentage of cesareans?
Actually, we used to do that hospital for postings.
What is the incidence of previous cesarean in this? What is the percentage of previous cesareans? Previous LSCs?
51.51%.
Is it mandatory to, subject the women for the LSCS if there is a history of previous LSCS?
Ma'am, can I repeat?
Is the LSCS mandatory if there is a previous history of LSCS for that woman? For the second pregnancy, LSCS is a requirement if the first pregnancy, the first baby was delivered by LSCS.
It's not like that it's always mandatory, ma'am. Depends on the patient condition we need to decide. Like in cases of emergency situations like placenta previa or fetal distress, like in that cases.
Thank you.
Thank you, Kusuma. Now we invite our next speaker, Piyush Pandey. I'd like to inform the rules once again. Each participant has only 6 minutes for the presentation and judges have only 2 minutes for asking the questions. Thank you. Once the 6 minutes are over, please give the ending statement, closing statement. Thank you.
Good afternoon, everyone. I am Piyush Pandey, MBBS Phase 3 Power student, here to present a mixed method study, the comparison between competence and psychological resilience between new and experienced healthcare workers. So as we begin, I want to share something that we are all aware that hospitals are a high-pressure environment where nurses constantly face emotional and physical demands. Resilience in our study is defined as the capacity to recover quickly from an adversity. And competence involves knowledge, skills, and behavior that ensures safe and effective patient care. The primary objective of our study was to understand the relationship between competence measured by the Richard scale and resilience measured by the CDS 10 scale. It was also to identify key factors that contribute to resilience, competence, and how they change across experience levels. Lastly, it was also done to document coping mechanisms employed by healthcare workers utilizing the brief code investigative questions. To our knowledge, this was the first study that combined all these three aspects into one study. The design was a mixed method observational study and it took around 8 weeks to conduct. And the technique employed was convenience sampling. The sample size was approximated to be 76 and we managed to collect that data via digital and physical forms for better comfortability and we made it available in English, Kannada and Malayalam. This was translated by a committee approach and for equivalence. On the right, you see a bar chart showing that there is a healthy distribution of participants. About 27 of them had less than 3 years of experience, which is close to half of our total participation. The key findings from the competency analysis show that there were 4 highest competence metrics that were accountability, clear communication with patients, effective communication with co-workers, and decision making. The 4 lowest competence metrics were discussing system failures with their role and disclosing an errors even to a patient, team dynamics and managing interprofessional conflicts. On this slide, you see a stacked bar chart showing that there is a steady rise in average competency scores as the experience increases. However, there is also a slight non-significant decline after 20 years. From the qualitative responses of the study, it was inferred that nurses with greater than 20 years of experience felt less competent due to being unable to keep up with rapid advances in medical technology. On this slide, you see resilience versus years of experience. There is a line chart at the bottom showing a steep rise in the average resilience score as the years of experience increases. On the right, you see a stacked line chart showing the top 4 resilience metrics represented by solid lines and the bottom 4 resilience metrics represented by dotted lines. This is a static plot showing resilience versus competence. As you can see, there is a total rise in total resilience score as competence increases. Both of these are self-assessed scores and you can see there is an increase on the scatter plot. This is a board curve showing the qualitative responses and you can see words like poor and situation talking appear very commonly. So analysis from this was there are common coping strategies like meditation, spirituality, humor, suggesting that participants often rely on relaxation techniques to manage with stress. And terms like guilt, self-blame, criticism indicate that some respondents experience significant self-directed negative feelings. Some unfortunately even told they had breakdowns at the workplace. Problem solving words such as plan, resolve, actions so that there was proactive approach by healthcare workers for dealing with stress. So our discussion part includes that there is a positive correlation between and higher perceived of competence tend to exhibit higher, stronger resilience. And also what we found out is that experience matters. Workers with more than 10 years of experience demonstrate significantly higher level of resilience and competence compared to early career professionals. Also, what we saw is early career professionals having less than 3 years of experience exhibited lower resilience. So what we finally conclude with is that we could humbly propose that there could be mentorship and support programs to help early career healthcare workers to develop resilience through guidance, and also there could be resilience building workshops and stress management training to help early career healthcare workers. And there could be workplace interventions made based on regular feedback. Studies such as this one could be conducted regularly, and that would ensure timely interventions and support for healthcare staff facing challenges. These were the references cited for my study. Thank you so much for your time.
What was the sample size?
Ma'am, the sample size was approximated to be 76. It was based on another study conducted for competence and resilience. It was based on that Rita Meritego study.
What was the method of sampling?
Ma'am, it was convenient sampling.
Means what?
The staff that were available at the hospital, we went and asked them questions, and we didn't have another method to sample. Whoever was available was asked questions, ma'am.
Who were your subjects?
Ma'am, nurses primarily, ma'am.
Only nurses?
Yes, ma'am.
Thank you.
Thank you.
Thank you, Piyush. Now I invite our next participant, Shubha SM.
Good afternoon, one and all. My name is Shubha SM, second year MBBS student from KLE JJ Medical College, and my title goes here, Monsoon's Hidden Heat, Unveiling the Acute and Differentiated Fever Trends, Hospital-Based Cross-Sectional Study. And my guide is Dr. Sisganga ma'am. So, before coming into introduction, I would like to give a small background onto this. Imagine a man comes to your clinic during the peak monsoon. He has high fever but no localized symptoms. So the challenge is, what is causing it? This is the mystery of acute and differentiated fever, and my research aims to solve it. So acute and differentiated fever is any febrile illness within 2 weeks of duration without any evidence of localized infections by history, physical examination, complete blood count, chemical profile, urine analysis, chest x-ray at the initial presentation of the department. And this is associated with wide range of non-specific symptoms like headache, body aches, chills, sweating, gastrointestinal disturbances, and others. So the main aim and objective is to study the clinical and laboratory profiles of AUFI patients during the monsoon season.
The materials and the methods. The source of data was collected from patients attending OPD and IPD of JGM Medical College Hospital. Hospital-based cross-sectional study for a period of 4 months, and the sample size was 60 cases. Technique convenient sampling. The inclusion criteria was all the inpatients fulfilling the AUFI definition were included, age more than 18 years, and the patient presented with fever less than 2 weeks of duration. Exclusion criteria were age less than 18 years if the fever is due to specific organ involvement, and the patients on immunosuppressive therapy, cancer chemotherapy, and HIV infection. Study protocol, it was done according after taking the institution ethical committee clearance, and various tests were used to do like rapid test, agglutination test for salmonella and brucella, and peripheral smear was used to diagnose the malaria. And statistical analysis was done using the latest version of SDUAHER software. The outcomes were like this. The average patient age is 42.6 years within a range of 18 to 85 years, with 62.5% male and 35.7% female. And most of the patients presented with fever, that is 80.4%, followed by diarrhea, 71.6%, and other symptoms included vomiting, headache, myalgia, 19.6%. And the causes were elicited to be 51.6% dengue, 22% salmonella, 21.5% mixed infections, 3.3% malaria, and 1.6% leptospirosis. These dengue cases peaked in August, while mixed infections were more common during July, particularly dengue with enteric infections. Treatment involved antipyretics, doxycycline, metronidazole with an average hospital stay of less than 7 days, and the mortality rate was 1.66%. So the complications associated with this were acute kidney injury, respiratory distress, platelet transfusion, inotropic support, respiratory support, and mortality. The discussion is acute undifferentiated febrile illness carry various it is a very challenging because due to the multiple causative agents and non-specificity in the symptoms. So serological tests were very useful to diagnose as they were easy to perform and results can be obtained within a few hours. In the present study, I can see that male population has more predominance, that is 62.5% compared to the female, that is 35.7%. This may be due to the outdoor occupational exposure of the males, and this finding is consistent with many Indian and international studies, including the studies from Uttar Pradesh. And dengue, malaria, scrub typhus, enteric fever, leptospirosis have been identified as major causes of AUFI in Thailand, Malaysia, Nepal, and few studies from South India also. These enteric fever cases are expected to rise during the monsoon due to the consumption of contaminated water, and the management is very poor due to the limited infrastructures and non-specific symptoms. Rapid diagnostic tests are also temperature sensitive. They lose their efficiency when stored at room temperature. So, from this study, I would like to conclude that treatment and diagnosis of acute undifferentiated fever needs comprehensive approach. And early diagnosis and timely intervention can minimize the morbidity and mortality of the AUFI. And most common etiological agents were dengue, salmonella, scrub typhus, mixed infections, and major cause for morbidity is due to renal involvement and respiratory involvement. And these are my references. I would like to thank Dr. M.G. Hiremat sir, Principal, Sharda Medgood, my Vice Principal, and Shruti Hiremat, Statistician, and I would like to thank SDUMC for giving me this wonderful opportunity to present this research paper. Thank you one and all.
What was the period of your research?
It was 4 months.
4 months, that is the duration.
Yes.
I am asking you the period, from which month?
May to August.
Which year?
2024.
May to August.
Yes, ma'am.
Okay. And what were the tests done?
Rapid tests were done.
All were card test or anything else?
Sorry, ma'am?
They were card test or strip test?
Card test.
Or they used it ELISA? What type of test was it?
ELISA was not used, ma'am. Rapid tests were most used due to the limited facilities.
Then it was the data collected from the record section, is it?
Yes, ma'am.
Okay. Thank you.
Thank you.
I now invite the fourth participant, Dhanvin.
Myself, Dhanvin here, second year MBBS student, Sisganga Medical College and Research Institute. My topic is the prescribing pattern of antimicrobial agents in adult population using WHO AWARE classification in a tertiary care hospital. My guide is Dr. Rishna. To begin with, antimicrobial resistance is a major public health problem and death due to AMR is projected to be 10 million by the year 2050. So it has emerged as a public health concern. So the main cause for this is misuse and overuse of antibiotics. To overcome AMR and to guide appropriate antibiotic prescription, WHO in 2017 has modified the essential drug list of antimicrobials and classified them as three categories, that is access, watch and reserve, based on their toxicity concerns and resistance potential. So the access group of antibiotics must be used as the first line for empirical treatment, while the watch group antibiotics are used for a small number of infections, and reserve group must be kept as a reserve or last option for a limited number of infections or severe infections. Since there is a lack of studies regarding this topic, our study gains its importance in assessing the prescribing pattern of antimicrobials and the knowledge and attitude of the clinicians towards WHO AWARE classification. So the aim and objectives of our study are to highlight the prescribing patterns of antimicrobials among clinicians using WHO's AWARE classification in a tertiary care center and to assess knowledge and attitude of prescribing clinicians with the utility of AWARE by questionnaire-based assessment. So these are the materials of our study. It was a cross-sectional study which was done over a period of 2 months, including physicians and their prescriptions containing antimicrobials. So the inclusion criteria were prescriptions which had at least an antimicrobial in both outpatient and inpatient setting of adult population. And the prescribing physicians who were willing to participate in this study to assess, so we wanted to assess their knowledge and attitude regarding this classification. So exclusion criteria were those physicians who did not want to participate were excluded. We used a validated semi-structured questionnaire which was distributed among the clinicians through Google Forms. So the sample size of our study was 180.
After obtaining institutional ethical committee clearance, informed consent was taken from the physicians, then prescriptions were collected from the IPD and OPD. Then we classified those antibiotics according to the WHO classifications as access antibiotics, watch and reserve antibiotics. Questionnaire-based survey was done and we assessed their knowledge and attitude towards the classification through Google Forms. Data was entered in MS Excel and descriptive statistics like percentage was derived using the info software. So among the 182 patient prescriptions we included, we noticed that there were 26 different antibiotics. So 73% of the prescriptions were collected from the IPD, while the remaining 27 were from the OPD. 32% of the prescriptions were from the surgery and allied departments, while 62% of them were from the medicine and allied departments. Ceftriaxone was the overall most common antibiotic prescribed. Doxycycline and ceftriaxone were the common antibiotics prescribed by the medical and the surgical departments respectively. So this depicts the percentage of antibiotics, that is 35% of them were access antibiotics, 54% of them were watch antibiotics, 7% of them were reserve antibiotics. So more of the antibiotics belong to the watch group. This graph depicts the prescribing pattern among clinical departments. So both medical and surgical departments prescribe more of watch group of antibiotics. However, medical departments prescribe more access antibiotics and less reserve antibiotics compared to the surgical departments. So this is the assessment of among the clinicians. 36% of the clinicians had heard about AWARE classification, remaining had not heard. Among those who had heard, only 32% of them were familiar and 52% of them were somewhat familiar. Remaining were not familiar but still had heard about AWARE classification. This is another question to assess the knowledge. More than 80% of the clinicians were aware of the adverse effects of the indiscriminate use of antibiotics antibiotics like emergence of antimicrobial resistance, prolongation of illness, adverse effects, ineffective treatment. However, only 52% of them were aware that even MMR and IMR would result due to AMR caused by indiscriminate use of antibiotics. So, assessing their attitudes, 44% of them were in favor of using the other classification in hospital to promote the rational use of antibiotics, and more than 40% of them responded positively so that aware could reduce the adverse effects of AMR. The present study was conducted to assess the knowledge and practices or attitude regarding the antibiotic prescription in a tertiary care hospital. The study also aspired to discover awareness regarding aware classification among the clinicians due to lack of studies on this. So we are comparing our study with previous studies, and among them, one study is very much similar to our study, that is conducted by Renoji et al. On 601 prescriptions, and they found out that cefixime was the most common antibiotic. 43% of them belong to access group, 46% to the watch, and 11% to the reserve group. In our study, we used 182 prescriptions. We found out that ceftriaxone was the most common antibiotic. 34.6% of all the antibiotics belong to access, was 53% to the watch, and 11% to the reserve group. So this is regarding the knowledge and attitude. See, we have obtained similar results to that of study conducted by Gochita. So 33.3% of them were aware of other classification in this study. In our study also 36% of them were aware of other classification. So regarding conclusion, the goal of aware classification is to bring about change in the prescribing pattern, and access group of antibiotics must be used for 60%, remaining must be used watch and reserve antibiotics. However, in our institution, only 34.6% of the antibiotics are from watch group. More of watch group are used in our institution. This could be due to the lack of knowledge or training. So we need to create awareness among the clinicians regarding AMR and the importance of aware classification. So this can be done by conducting workshops, CMEs, textbooks, or any other means. So continuous monitoring of antibiotic prescriptions can also prevent this. So these are my references. I would like to acknowledge these people for their continuous support. Thank you.
What was the period of your study?
We conducted this study from July to June to August.
How did you calculate your sample size, the number of participants?
We used the previous studies we used the convenient sampling method.
How did you validate your question?
It was taken from a previous study, so it was validated by the experts in those studies.
How exactly you validated? What's the procedure?
They used experts who are not included in the study. They did some pre-testing and post-testing to assess this.
Thank you.
Thank you.
One second. How many doctors were included? How many physicians were given the Google form to fill?
Around 95 physicians were used.
And was it a retrospective, was it an audit, or you did a prospective study?
It was an audit.
It was an audit.
Thank you.
Thank you, Dhanvir. I invite my next participant, Dr. Aditya Sridhar.
Hello. Good evening, I'm Dr. Aditya Sridhara. So, how many of you love the smell of wood fire? Yeah, me too. So, growing up, thought the smell of the wood smoke in the kitchen meant a cozy home. Little did I know it caused a lot of air pollution. Turns out there's a lot more happening in rural households than just cooking a dinner. Today, we are going to look at how the charming scent can actually cause some serious indoor pollution. So, my topic is indoor air pollution among rural households. So, introduction. For many developing countries, indoor air pollution is the largest environmental problem, as so many of them do not have access to clean fuels. So, Indoor air pollution could be burning of the solid fuels like charcoal, coal, crop waste, etc. Burning these fuels produces particulate matter, which is a major health risk. Recent literature shows this is a major risk factor, causes of death like heart disease, pneumonia, stroke, intrauterine growth retardation, etc. So the burning of these such fuels causes the exacerbation of these diseases. So maintenance methods. This was done in our rural households, which out of 5 PHCs in Kolar, 5 were randomly picked. It was a cross-sectional study, which was a study period of 2 years from June 2022 to June 2024. Study participants were household participants who were aged 18 years. Sample size was taken from the study done in Kolkata, which showed 49% of study population in rural areas when suggesting indoor purposes using cooking fuels with an error of 5%, 95% of confidence interval sample size was calculated, which was 400. Sample size calculated was based on sample size formula, sample size is 4PQ by D square. So study tools used to assess was modified DG Prasad classifications to assess socioeconomic status. A semi-structured performer was used to collect householding standards. Air quality indices was the main various parameters, which is the main base used for this. So air quality index is a tool effective to communication of air quality status to the common people like us to understand what is it. It includes transforms complex air quality data to various pollution into a single number, which categorizes namely good, satisfactory, moderately polluted, poor and very poor, and severe. So air quality index, there are mainly 8 pollutants, which are particulate matter size 10, particulate matter 2.5, nitrous oxide, sulfur dioxide, carbon monoxide, ozone, ammonia, and lead. So the statistical analysis was done using Microsoft Excel, using a software from IBM Corporate SPS as version 222. So indoor air quality with chi-square was applied with level of significance defined as p-value less than 0.05. Ethical clearance was obtained from institutional ethical committee before the study of the start. Consent was taken and participants' names and personal details were never recorded. So this is the results. This table shows us the distribution of study participants according to their socio-demographic profile. More than 25% were between 13 to 14 years of age group, 52% were females, and more than 86% were nuclear family, and more than 60% were upper middle class. So, study of participants according to their external housing conditions, most of them had independent access to a street, which was 77%, and most of them had always inverted to smoke, excessive noise, dumping and refuse around the house, and most of the breeding of flies everywhere. So this shows the distribution of study participants according to the internal house conditions. Most of the houses had detached houses, walls were plastered, and which was crucial part of the study was 84% of the ratio of the window space to the floor area was less than 1/5, and doors and window space combined to the floor were less than 2/5. So this pie chart shows 688 houses were pakka and the remaining were 124, and most of the houses had either single rooms or 2 rooms in the entire house. This graph shows us the air quality indices and various air quality parameters. So more than 192 houses with poor air quality index was there, and 580 was moderate. And particulate matter 10 was more than 772 houses had moderate amount of air quality index with it. And PM2, particulate matter 2.5, the houses were 144 with moderate and 568 were satisfactory. But the most important part comes where the total volatile organic compounds, more than 384 houses were moderate and 428 houses were very poor with TVOC. So these are the tables of association between external environmental factors and housing conditions. As the time is constrained, I'm going to just tell this just about these graphs in my conclusion. So discussion. These similar studies were done in India by Goel et al. Also showed that indoor air quality was poor among such households, which used agarbatti, cooking oil, intense dhoo, mosquito coil, cigarette, and charcoal. Study done by Kuttiswamy et al. In Chennai during COVID lockdown also showed that significant reduction in indoor and ambient levels, which the highest reduction observed during lockdown phase 2 and phase 3. The study showed that uneven reduction in ambient and indoor attributed to overcrowding and many other factors. A review article was published by Gopalakrishnan et al. Among Indian buildings showed that Indian air quality get poorer to reasons like smoking, incomplete combustion of solid fuels, improper ventilation. In India, there is no proper standard for indoor air quality assessment like ambient air quality assessment. Conclusion. This small monitor, which is smaller than the size of hand, is cost 70,000 and which tells all the parameters which are required to consider AQI. So my sample size was 812 households which showed 582 moderate AQI and 192 poor housing standards. Factors like smoke, soil dry, safe and well-dried breeding of flies, traffic were few external factors influencing AQI, and factors like type of house, number of living rooms, ratio of window space to floor area, door window space, ratio combined with floor area, cross ventilation, lighting, which are the few internal factors influencing air quality index. Measures must be taken for regular survey of AQI for households by Ministry of Health and Family Welfare. All this is a silent pandemic which has to be recognized. So these were my references. I thank all the household participants and Demedcon organizers for giving me this. Thank you.
Who were the participants?
All the villagers, people in the house, where they stayed more than 10 years in the same house in 5 rural PHs near Devara Samudra.
Something else was written some 18 years.
Yeah, study participants were taken age and 18 and above. People who work, who live in the houses, women who.
Regarding your results, what do you mean by less than 0.001?
That shows it is major risk. If the my chi-square value, if it was 0.05, we took it as it is involved. That means that factor is influencing air quality index and pollution in the household.
Which were the factors involved?
Mostly the factors involved were burning, cooking in the households like single room or 2 rooms in the house, overcrowding or not, away from the breeding places, proper drain, if they are in a pakka house or kacha house. Thank you.
Thank you, sir. Now I invite the 6th participant, Nitin Gowda.
Myself, Nitin Gowda, third year MBBS student from Chamaranagar Institute of Medical Science. I am presenting about the topic cytomorphological patterns of palpable breast lesions on the fine-needle aspiration cytology and its histopathological correlation. I will give a brief introduction about the breast cancer. Breast cancer is the most commonest malignancy among the women globally. It has now surpassed lung cancer as the leading cause of global cancer incidence in 2020 with 2.3 million new cases and 11.7% of all cancer cases. Lumps are very common presentation of breast pathology for women of all ages, particularly during reproductive years. Patients are reported at advanced stages of the diseases due to the unawareness, low socio-economic status and lack of screening facilities with existing social conditions. As per Demedcon 2020 data, in India, breast cancer accounted for 13.5% of all cancer cases and 10.6% of all deaths related to cancer. As the breast lesions are difficult to found out by clinical examination, fine needle aspiration cytology was introduced as primary test in diagnosis of breast lumps. Aims and objectives of my studies is to study the cytomorphological patterns of palpable breast lesions on FNAC, to classify the breast lesions under Yokohama system given the breast lesions under Yokohama system given by International Academy of Cytology under 5-tier system, which I will be explaining in further slides, and to correlate with the cytomorphological diagnosis with histopathological features. The methodology is to, it was a cross-sectional study and retrospective study with sample size of 285 cases with a duration of 2 years. The data was collected from archives in the Department of Pathology, SIMS Teaching Hospital, Chamranagar, where the patients present with the palpable breast lesions in OPD. The procedure of FNAC was done with the informed consent taken in the local language with thorough clinical and physical examination. The FNAC was done using 23 gauge needle attached to 10 cc disposable syringe. Smears were fixed with 95% alcohol and stained with HND stains. The cytopathological slides will be reviewed and reported as per International Academy of Cytology Yokohama system for reporting breast cytopathology. According to Yokohama system, breast lesions are classified into 5 categories. In C1, the smears containing insufficient information. In C2, it contains benign breast lesions. In C3, the cytomorphology with atypical presentation or with proliferative breast disease with atypia. In C4, of suspicious of malignancy. In C5, confirmed malignancy cases. For selection of subject, we follow inclusion and exclusion criteria. In inclusion criteria, we take all female of different age groups who presented with palpable breast lesions and males who presented with palpable breast lesions. And in exclusion criteria, we exclude any patient with any bleeding disorder or skin disorder or with any recurrent malignancy. These are the results of our study in which C2 includes benign lesions. It is further divided into inflammatory breast lesions and benign breast disease, which are subdivided into acute inflammatory lesion, granulomatous mastitis, fibroadenoma, fibrocystic disease, and gynecomastia, in which fibroadenoma and fibrocystic disease contains a majority of the cases with 47.87% and 19.85% of total cases, and malignant lesions comprises of the 11.34% of the total cases. This table gives us the idea about the palpable breast lesions among different age group. If we observe clearly, most of the benign cases are presented in age groups between 10 to 20 years and 41 to 50 years, and most of the malignant cases are presented in the women above the age of 45 years. On cytomorphological interpretation, in this, out of total 285 cases, 218 cases are categorized under benign category, 31 in atypical category, 3 were suspicious of malignancy, and 32 were confirmed malignant cases. Breast lesions are most commonly seen in upper outer quadrant with 29.72% of total cases, followed by upper inner quadrant and multiple quadrant. Out of 285 cases, 47.8% of them presented with the painful presentation, 43.26 of them presented with the painless presentation, and 8.8% presented with nipple discharge with the association of pain or painless presentation. Gynecomastia was more commonly seen in elderly male in age group between 45 to 70 years. The FNAC of our laboratory has shown the sensitivity of 100%, specificity of 98.4%, positive predictive value of 99.5%, and negative predictive value of 100%. These are the FNAC pictures of fibroadenoma and infiltrating ductal carcinoma. In fibroadenoma, we can observe that benign ductal epithelial cells which are in tight cohesive clusters. In the background, we can see the bare nuclei. In the infiltrating ductal carcinoma slide, we can see atypical cells with pleomorphic presentation. These are the histopathological images. I conclude by telling that present study showed the 99.6% diagnostic accuracy of cytological reporting of breast lesions based on the Yokohama reporting system. FNAC has become widely accepted procedure as an efficient first-line diagnostic test in the management of breast lesions. Yokohama reporting system foster better communication between clinician and the institution to improve overall patient care with a clear guidance on categorizing lesions. These are my references. Thank you.
What was your study degree?
Ma'am, from June 2022 to July 2024, ma'am. 2 years.
Study duration you are telling. Study design I asked.
Ma'am, retrospective study, ma'am. And cross section.
What's the method of statistical analysis you had?
Ma'am, based on the FNSC register, we have collected data, ma'am.
Statistical analysis. How many male breast, lesion you considered?
Ma'am, we mainly considered 5 types of breast lesions. In benign category, we subdivided into another 6 categories.
Male cases?
Male cases 13, ma'am.
13 out of?
Gynecomastia, out of 285 cases, 13 cases were of male cases.
How do you concluded the sample size?
Ma'am, we calculated based on the previous study, ma'am, conducted by Sharif et al.
What's the triad of breast cancer screening?
Ma'am, first we use USG mammography, ma'am. Then ultrasonography, then FLC.
You wrote the Demedcon percentage, that is prevalence of cancer. What is the prevalence of cancer in Karnataka and in India?
Ma'am, in India, 13.5%. Thank you.
Why? Where are the lesions more common? Is it more common in females or males?
It is more common in females, ma'am, especially in postmenopausal females. Malignant lesions are more common.
So why did you include both females and males in your study? Because the spectrum is different. Males have a different type of lesion. Most commonly, it is different in females and different in males. So why did you club both?
Ma'am, in the previous one study, according to my analysis, I included both females and males.
Thank you, Nitin. I now invite my next participant, Sakshi Bora. I hope I am audible. A very good afternoon to respected judges, faculty members and my dear colleagues present in the auditorium. I, Sakshi Bora, third year UG student of MBBS, am here to present my research titled Study of Fluoride and Thyroid Profile Status in Pregnancy of Second Trimester Women. It's a cross-sectional study. The study has been done under the guidance of Dr. Muni Lakshmi U. This study has been submitted to STS Eisenbar and has been approved by the same. The study place Kolar is declared as fluoride endemic area due to increased depth of groundwater levels, and the fluoride content in the groundwater has exceeded significantly from 0.4 to 4.6 parts per million. Even though fluoride not an essential mineral to the body's function, WHO recommends fluoride in drinking water 1.5 parts per million. It's well established that excessive amount of fluoride erodes dentine of teeth and structure of bones, leading to visible manifestations like skeletal and dental fluorosis. Apart from this, one hidden aspect of fluoride exposure in prenatal time period holds great importance. It leads to diminished intelligence quotient scores among children living in areas with high levels of natural occurring fluoride in drinking water, as well as more risk to ADHD in children. Implications of fluoride in thyroid hormones during pregnancy is relevant to cognitive abilities in the offsprings. Why is it important? It's important because fetus entirely depends on maternal thyroid hormones until mid-gestation and continues to be partially dependent up to birth. Studies regarding the effects of prenatal exposure and endocrine system are limited and are inconclusive. In this regard, this study has been planned to find the association of fluoride and thyroid hormones in pregnancy of mid-gestation, which is a vulnerable window, and also to observe to what extent the fluoride compounds thyroid disruption.
Based on the study, objectives were framed as follows. To estimate and compare serum fluoride with thyroid profile and hemoglobin levels, to correlate fluoride with thyroid parameters and hemoglobin. Study design is cross-sectional study and purpose is sampling. Study area is the pregnant women attending OPD of OBG department at Jalapa Hospital attached to Sri Devarajas Medical College, constituent of SDUAHER. Based on the mean differences of thyroid profile in pregnancy, the sample size was calculated with 80% power and 95% confidence intervals with minimum sample size of 38 per group. Inclusion criteria of my study were healthy pregnant females for less than 35 years of age with gestation period from 13 weeks to 27 weeks. Age matched clinically proven healthy non-pregnant females. Subjects which are excluded were pregnant females diagnosed with preeclampsia according to the ACOG guidelines, women with gestational diabetes and other comorbidities. Ethical clearance was obtained, and here are the copies of patient information sheet, consent forms, and case report. This was provided to the subjects in local language also. The sample which we collected for our study was segregated into these following parts. Sodium chloride tube for the plasma glucose levels, EDTA tube for hemoglobin percentage, and plain tube for the routine biochemical analysis. These are the parameters which we have assessed in our studies using the respective instrumentations. Statistical analysis we did using SPSS version 23, the normality distribution of variables assessed, and then student t-tests and Pearson's correlation test were used as we compared two groups. Student t-tests performed to compare means between the two groups, and Pearson's correlation test to identify strength of linear relationship between two variables. This is a comparison between the two groups, and significant differences were observed in T3, T4, TSH, and serum fluoride. Table 2 shows the correlation of serum fluoride and thyroid hormones, where we see a significant negative correlation between fluoride and hemoglobin. Table 3 shows correlation of hemoglobin and thyroid hormones, where also we see a significant negative correlation with hemoglobin and T4. This is a triple axis curve in which we can see the different correlations of all the parameters which we have used for the study. Here in the second row, we can see the negative correlation between the parameters as we have depicted in the tables. Moving on to the discussion, table 1 represents significant increase in T3 and T4 in mid gestation compared to controls. However, concentration of TSH is significantly decreased in group 2 compared to group 1. As we all know, physiological changes in thyroid is there, which is normal and which is not detectable easily by the clinicians, and it does not require any treatment. Two key gestation hormones, namely HCG and estrogen, cause increased thyroid hormones levels in the blood. These two hormones are physiological. It does so because the similarity between the alpha subunit of beta HCG with the thyroid hormones. So these physiological hormonal changes sometimes make thyroid function tests during pregnancy difficult to interpret. Present study observed hemoglobin and serum fluoride was significantly decreased in pregnant subjects compared to the controls. We have observed serum fluoride significantly positively correlated with hemoglobin in pregnancy subjects. Our findings were consistent with the study done by Sushila A.K. et al. And Gupta S. et al. As per their observations, females with elevated fluoride levels have more chances to pregnancy complications such as anemia and adverse fetal outcomes and congenital malformations. This is according to A.K. Sushila et al. Intake of fluoride-free water and food decreases the incidence of preterm deliveries by 4 times. Iron deficiency or anemia also plays an important role, since it impairs hepatic T4 dehydrogenase, an enzyme which converts T4 into T3, which is the active form. Transplacental fluoride passage fluoride is transmitted through the placenta to the fetus, while the benefit of fluoride intake during human pregnancy is still debatable. SWOG analysis of my studies are here. Based on the findings of research, authors would like to make following recommendations: timely screening, ultrasound examination for congenital malformations, etc. To conclude, excessive fluoride intake during the early pregnancy may lead to increased prevalence and severity of maternal anemia as well as adverse fetal outcomes. Take-home message of our study is, considering the adverse outcomes of fluorosis in pregnancy, the study shall enlighten clinicians and community to local population to aware of fluorosis and importance of using filtered water installed in the community of most of the villages, which can be done by the family adoption program which we are undergoing. Thank you. How much of the blood was collected?
Sorry, ma'am?
How much of the blood was collected?
200, whatever the
different pig. So we collected directly from the CTLS lab.
Collected agree, but how much?
Around 300.
Did the participant give you the consent?
Yes, ma'am. In local language, we also submitted the information.
So finally, how was the fluoride related with associated with thyroid hormones?
Ma'am, fluoride has greater, it's hidden actually, not much studies have been done in this aspect.
I'm asking you the outcome of your study.
Ma'am, it is leading to a decreased intelligence quotient among children, which we have observed.
The results of your study, the fluoride levels versus the thyroid profile.
It is negatively correlated, ma'am. So increased fluoride exposure is leading to disruption thyroid hormones maternally, which causes placenta and induce changes in the fetus.
What are the two groups in your study?
Ma'am, group 1 and group 2. Group 1 is the clinically proven healthy subjects and group 2 second trimester subjects.
Why did you compare pregnant and non-pregnant?
Ma'am, because we wanted to test in the vulnerable window, which is the second trimester, which is a crucial period for fetal development. So we had to get a novel controls. So
How do you know that group 1 is normal?
ma'am, we tested for the other biochemical parameters. We excluded the comorbid conditions in females.
What was their fluoride levels? Was it normal or elevated?
It was normal. 0.14 and the mean is 0.14.
And how many of the pregnant patients had elevated fluoride levels?
We have taken a mean, so we not individual values, we are not sure, but the mean is elevated.
How many patients had normal fluoride with hypothyroidism?
This segregation we did do, all the wet gestation samples we collected and we took a mean of it. Thank you.
Thank you, Sakshi. Now I invite our next participant, Sagar.
Good afternoon, everyone. I'm Sagar. I'll be presenting to you about my research paper titled Self-Medication Practice Among Patients and Their Knowledge of Reporting Adverse Drug Reactions in Tertiary Care Hospital. Self-medication is a practice of using medication or treatment for physical, psychological disorders without medical guidance. Self-medication can be easily accessible, but it possesses major threats. For example, antibiotic resistance can lead to antibiotic-resistant bacteria, which is very harmful, or use of inappropriate drugs, which can lead to ineffective treatment, or it can mask major medical conditions which may cause harm in the future. Over-the-counter medications are easily accessible, but possess several threats when especially combined with other drugs or medical conditions, highlighting the need for more study on adverse drug reactions and self-medication. Objective for my study was to determine the knowledge, awareness, frequency, and severity of areas related to self-medication among patients and to describe their main characteristics. Methodology. It was conducted in Maidagi Institute of Medical Sciences and Research Center on patients aged between 18 to 70 years using the questionnaire survey. The first part of the questionnaire mainly collected the socio-demographic details of the patient. The second part of the questionnaire collected the self-medication practices done in the past 1 year, and the third part of the questionnaire collected about the adverse drug reactions the patient experienced. Total 144 patients were taken. Out of which 74 were males and 70 were females. Most of the respondents were 18 to 30 years and 51 to 60 years of age. Most of them were homemakers or office lovers. 24 patients had comorbidities. Most of them had graduate level of education and worked between 6 to 10 hours per day. The major symptoms prompting for self-medication were fever, backache, and knee pain. The major drugs used were NSAIDs, cough syrups, antihistamines, antibiotics, etc. Most of the patients did not experience any areas, but 9.8% patients experienced ADR and were hospitalized for symptoms such as rashes, Stevens-Johnson syndrome, gastritis, etc. NSAIDs were the mostly used over-the-counter medications, followed by antibiotics and antihistamines. Here are some case studies which were taken from our hospital. A middle-aged female developed rashes on her arms after consuming ciprofloxacin 500 mg for 1 day, used it twice a day and was hospitalized. Another patient who used azithromycin 500 mg once a day was hospitalized after 1 day after developing rashes on her arms and forearms. A 35-year-old male who took amoxicillin and carbonic acid 625 mg was hospitalized after 2 days after consuming twice a day. A middle-aged man who consumed toxin syrup for cough developed rashes on his face. A COPD patient took amoxicillin for 3 days for fever and cough and then developed diarrhea, for which he took metronidazole and then developed Stevens-Johnson syndrome. Similarly, a 48-year-old patient with no past history took terbutaline syrup for cough, developed muscle cramps and was diagnosed with hypokalemia. Here are few cases where self-medication was done without physician's guidance. A middle-aged man developed rashes on his hands after consuming gabapentin 1000 mg per day. Was hospitalized after 5 days, which was suggested by his cousin, a diabetic. Second case where a patient 17 years old was a known case of epilepsy, was on Phenytoin 100 mg twice a day, stopped medication after 9 years, and the symptoms were better. After 3 years, he developed the symptoms again. He restarted the medication, and after 3 years, he came to the hospital with gum hypertrophy. A 58-year-old female was prescribed methotrexate 7.5 mg once a week. She misunderstood the medication and took it every day. After a week of medication, she came with Stevens-Johnson syndrome. In the present study, 9.8% subjects had anemia and 94.4 subjects didn't know about what anemia is. Similar study conducted by Muhammad Ashraful Islam showed a mean score of knowledge of 5.46 and reporting of suspected area was 3.43. A similar study done by Muhammad Rashid et al. Showed the mean prevalence of self-medication practice in India to be 53.57%. My studies showed that high prevalence of self-medication, limited knowledge of adverse drug reaction, and severity of adverse reaction. So strategies must be designed to raise awareness, educate the patient for effectiveness of pharmacovigilance system, and an urgent need for regulatory control over self-medication to safeguard from harm. These were the references used. Thank you.
Who were the
All the patients, inpatient and in the ward patients, are between the age group of 18 to 70 years.
sample size?
Sample size was 144.
How did you conclude the sample size?
Similar studies were taken and the duration of my study was considered and the sample size was calculated using the SPSS software.
You had the questionnaire studies, right?
Yes, ma'am.
How did you validate your questionnaire?
It was also considered from 2 or 3 similar research papers.
The people who are admitted, you got the information. What about the people who are not admitted?
It was a questionnaire based.
So who are your subjects?
Any patient, any person who is between the age group of 18 to 70 years who comes to the hospital. OPD and as well as IPD patients.
Was it a retrospective study or was it a prospective study?
Prospective.
Prospective. For how long?
It was for a duration of 7 months.
7 months you got so many drug reactions?
Yes, sir.
What about the ethical clearance?
Ethical clearance was obtained from all the patients had given their consent before the questionnaire, sir.
Thank you, Sagar. Now I invite the next participant, Aditi.
Good evening, everybody. I'm Aditi, a third-year MBBS student, and I'll be presenting a study on a survey of glaucoma awareness, knowledge, and practices among urban and rural population. Glaucoma is a progressive optic neuropathy and the leading cause of irreversible blindness worldwide. Studies have shown that 50 to 90% of the glaucoma cases remain undiagnosed and a large number of cases are diagnosed at a later stage of the disease. Assessment of awareness is the first step of disease management. Hence, this study was done with an aim to design a more effective glaucoma awareness and screening program in the future. The objective of this study was to assess the knowledge, awareness and practices regarding glaucoma in South Indian urban and rural population, to compare the knowledge, awareness and practices regarding glaucoma in South Indian urban and rural population, and to compare the knowledge, awareness and practices regarding glaucoma in the South Indian male and female population. The study was done over the area of South India. It was a cross-sectional survey done over the duration of 3 months. It included rural and urban population of South India about 20 years of age, and the exclusion criteria included medical professionals and people diagnosed with or on treatment of glaucoma. This is the performer that was used to conduct the study. The sample size estimation was done by the sample size estimation formula. The minimum sample size that was obtained was 38, but a higher number of samples of 105 was considered for the study. The methods of the study, the data was obtained from a validated questionnaire. Part 1 contained questions pertaining to demographic details. Part 2 had a total of 10 questions, 4 evaluated the awareness and 6 assessed the knowledge. Part 3 had 2 questions that assessed the practices. Each question were given 3 responses, yes, no and do not know. Participants who agreed to take up the study were asked if they have ever heard about glaucoma. If yes, they were asked to take up the questionnaire, and the completed questionnaire was considered for the final data analysis. The statistical analysis was done with MS Excel, and it was analyzed using SPSS version 23. These two graphs show the educational status differences between the rural and urban population and the male and female. Coming to the results of the study, awareness of glaucoma, urban population was shown to be more aware, which was 91.9%, and male population of about 88.1% were aware about this condition. Coming to the knowledge about glaucoma, urban participants generally exhibited a higher awareness, where 91.1% had heard about the disease, and males tend to show greater knowledge, where 65.7%, especially regarding the prevention of blindness. Coming to the practices regarding glaucoma, urban population has more practices related to the screening, which showed 38.3% prevalence, and male population had a slightly more practice related to screening, which was 35.1%. This study helped us realize that there was a high awareness of glaucoma with significantly more awareness among the urban population. Majority believe that risk increases with age. 52.4% of the population acknowledged that anybody can have glaucoma. 57.1% believed blindness from glaucoma can be prevented, and 63.8% understand that treatment is possible. The common misconceptions that were considered during the study was that notably 28.6% of the population related glaucoma as cataract, indicating a need for better education. To conclude, awareness of glaucoma is generally high but varies significantly between urban and rural populations. Glaucoma knowledge gaps exist largely due to less information, education, and communication of the disease. Increased educational initiatives targeting rural areas to enhance understanding of glaucoma's risk and treatment options is beneficial. The importance of regular ocular checkups have to be emphasized, as only 33.3% underwent screening in the past year. The future aim is to develop community outreach programs and informational campaigns to address the disease and the misconceptions. The future aim is also to leverage various media to improve awareness about glaucoma. Coming to the monitoring and evaluation, establishment of metrics to assess the impact of educational programs of awareness and screening practices is beneficial, and to conduct follow-up studies to evaluate changes in the knowledge and behaviors over time. These are the references. Thank you for your time.
How did you select this urban and rural population?
Ma'am,
Ma'am,
Where was the study done?
ma'am, it was a questionnaire that was a Google form and a practical questionnaire that was given out, and it was done over South India, and the participants that were concerned were 60% rural and 40% urban.
Which place it was done?
Ma'am, Karnataka, Hyderabad.
Please repeat.
Some questionnaires were sent to like people staying over in Hyderabad, Chennai, and majority was Karnataka.
My point is, how did you classify urban and rural?
Ma'am, depending on the location,
Huh?
depending on the location where they stay.
What was the period of your study?
3 months. It
What's
was
the
from
duration? 3 months is the duration.
May to July of 2020.
What's the inclusion and exclusion of your study?
Inclusion is the urban and rural population above the age of 20 years, and exclusion was medical professionals and people who have been diagnosed with the condition.
But it was not mentioned. And the objectives?
Well, these are the objectives. And
Just
the
further, just
inclusion and
further.
exclusion.
Objectives?
You had people from rural area. How did you communicate with them? Ma'am, Kannada. The form was in English and Kannada.
So what is the term you used for? In Kannada, what do you tell for glaucoma? What is the word you used?
Ma'am, they usually describe it as curing one eye or more pressure over the eye.
Now, what is the terminology used when you send a Google form?
Sorry, ma'am?
What is the
Ma'am,
terminology
for
for
rural
Google?
patients, we didn't send a Google form. We used a questionnaire.
Questionnaire. So that questionnaire will contain a
Contain
question.
a pressure about
How did you communicate with them? Did you take a Google form or?
Ma'am, I used a few friends to translate from me.
How many states do you do this study?
Ma'am, it was only Karnataka and Andhra Pradesh, a few people from Andhra Pradesh.
And how did you distribute it to rural areas and urban areas?
Ma'am, urban areas, I sent a Google form, and rural areas, most of the people whenever we went for community medicine postings, I gave them the form.
Only in Karnataka?
Yeah.
Only our
Yeah,
area?
the urban population from Hyderabad was considered.
You put it as South India. South India has 4 or 5
Ma'am, I tried to
states.
like, get a lot of people, but the sample size was unnecessary.
Why did you select glaucoma? What is more common? What is the incidence of glaucoma?
Ma'am, I selected glaucoma because it's a leading cause for irreversible blindness, and the incidence is almost 2.6% here. So if you convert it, it's almost 11.2 million people in India suffer from the disease.
Thank you, Aditi. Now I request the next participant, Anupama Narayana, to take over the stage.
Good evening, everyone. Myself, Anupama. And my topic is prevalence and anthropometric predictors of metabolic syndrome and type 2 diabetes mellitus. So metabolic syndrome consists of a constellation of metabolic dysregulations including atherogenic dyslipidemia, central obesity, hypertension and insulin resistance. It is estimated that 25% of general population and 70 to 80% of type 2 diabetes patients have metabolic syndrome. So it is imperative to diagnose metabolic syndrome not only for the higher risk of development of type 2 diabetes but also individual components of metabolic syndrome hastens the complications of type 2 diabetes. So these are the criteria which are used to diagnose metabolic syndrome. WHO criteria, IDF criteria, that is International Diabetes Federation criteria, NCD-ADP, National Cholesterol Education Program, Adult Treatment Program 3, or GIS criteria, that is Joint Interim Statement. As the diagnosis of metabolic syndrome involves invasive laboratory tests to determine plasma lipid profile, glycemic rates, its inclusion on a large scale in routine monitoring of health status is complex. So in this sense, efforts have been directed to attempt to indicate more affordable and inexpensive alternatives for epidemiological tracking and thus as direct specific procedures to those at risk of developing metabolic syndrome. Besides diagnostic standardization, it is important to prevent syndrome onset, considering the economic impact on the treatment of the risk. So various anthropometric parameters like waist circumference and BMI play a vital role in prediction of metabolic syndrome. So studies have shown that additional anthropometric parameters like neck circumference, wrist, calf circumference, triceps skin fold thickness could predict dyslipidemia, diabetes, and cardiovascular mortality and metabolic syndrome. So the objectives of our study is to find the prevalence of metabolic syndrome in patients with type 2 diabetes mellitus attending the endocrinology OPD using the metabolic syndrome criteria, as well as anthropometric predictors of metabolic syndrome in patients with type 2 diabetes mellitus. So the study design is a cross-sectional study done for the duration of 6 months and 210 minimum required samples. So the inclusion criteria was the patient's age between 18 to 75 years with type 2 diabetes mellitus, and exclusion criteria were other types of diabetes, pregnancy and lactation, acute and chronic systemic illnesses, CKD, and grade 2 goiter. So the study included 2 type 2 diabetes patients who visited the endocrinology OPD of YDB between September 22 to February 23 after obtaining written consent, detailed history, and anthropometry, which were height, weight, BMI, neck circumference, wrist circumference, waist circumference, mid-calf circumference, and triceps skin fold thickness was recorded. And most of the patients came with the lab reports, so those values were collected. And they were categorized into metabolic syndrome. So the data was tabulated in MS Excel sheet and analyzed using SPSS version 21, and these were the statistical methods used. Coming to the results, so the mean age was 49 years in the total population, and in males was 50 years, and in females was 48 years. And coming to the results, the mean height and weight was higher in males, whereas BMI was similar in males and females. And anthropometry, waist, wrist, neck, and mid-calf circumference were higher in males, whereas triceps skin fold thickness was higher in females. And the rest of the criteria showed similar results in males and females, which was not statistically significant. And coming to percentage prevalence of the criteria, modified NCP 853 or JS criteria showed highest prevalence, that is 77.8%, and followed by IDF, that is 67%, followed by WHO criteria, which was 40%. Coming to individual parameters, percentage prevalence, triglycerides showed the maximum percentage prevalence, that is 56%. Percentage of positivity 56%, followed by waist circumference, and the least was showed by microalbuminuria, that is 14%. So coming to the inter-criteria agreement, modified NCP 853 or JS criteria versus IDF showed good inter-criteria agreement, followed by the other criteria. So this was the ROC analysis done using modified NCP 853 or JS criteria by various anthropometric parameters. Using this criteria, neck circumference showed maximum area under the curve at the cutoff of 35.5, which had maximum sensitivity and specificity. The same was done using IDF criteria, which showed mid-calf circumference had the maximum area under the curve, and at the cutoff of 33.5, which had maximum sensitivity and specificity. Coming to the discussion, as stated before, in the study of 212 patients with type 2 diabetes, the observed prevalence of metabolic syndrome was much higher using modified NCP 853 or JS criteria, that is 77%, compared to IDF criteria, that is 67%, followed by WHO criteria. Inter-criteria was good between modified NCP 853 or JS and IDF, and was poor when IDF criteria was compared to WHO criteria. Similar results was obtained in the study by Yadav and group and Haveri and group. In the present study, there was no significant difference of metabolic syndrome between males and females using either of the 3 diagnostic criteria. Among individual components of metabolic syndrome, triglycerides had the maximum prevalence, followed by total obesity or waist circumference, and the lowest prevalence was noted using microalbuminuria. In the present study, as stated before, neck circumference predicted metabolic syndrome better when diagnosed using modified NCP 853 or JS criteria, but when IDF criteria was used, mid-calf circumference diagnosed metabolic syndrome better. So the similar studies were also found in Kyung Kim et al. So the limitations of the study was a smaller sample size. Results of our study needs to be validated in larger groups, and this is a cross-sectional study. And prospective studies may give better description of effectiveness of each component of metabolic syndrome. Coming to conclusion, highest prevalence of metabolic syndrome in type 2 diabetes was given by modified NCP 853 or JS in metabolic syndrome in type 2 diabetes. These are my references. Thank you.
So what is your final take-home message?
Now we have to find like more inexpensive alternatives for like epidemiological tracking and to predict metabolic syndrome earlier in patients with type 2 diabetes, so that we can start treatment earlier and prevent hastening of complications of diabetes.
Participant, type 2 diabetes.
Yes, yes. I can understand.
How did you select your participants?
Ma'am, it was done by patients attending endocrinology OPD. So first we selected the patients who have type 2 diabetes, and then we took the lab investigations, reports which they had, and then we categorized into metabolic syndrome. So we found whether they have metabolic syndrome or not. And in those patients who have metabolic syndrome, we found which anthropometric parameters were higher, and those were used to predict in patients who did not have metabolic syndrome but were diabetic.
It was type 2 diabetes.
Ma'am, based on the history and based on mainly on the history they gave and the need for insulin and based on the presentation they have, most of the type 1 diabetes patients present with decay and early need of insulin. So mainly based on history and the lab we did that. Most of the patients we considered who were diagnosed as type 2 diabetes.
Any particular duration of diabetes? Did you take any cutoff value for the duration of diabetes?
No, that's happened.
Recently diagnosed diabetic?
Yes, no, we have taken it.
Did they have metabolic syndrome?
Ma'am, it varied among the patients. Some patients had metabolic syndrome when they were newly diagnosed as type 2 diabetes, and some didn't.
Thank you.
Thank you, Anupama. Now I invite the last participant of this event, Dr. Arunam Patel.
Good afternoon, respected leaders and my dear friends. Myself, Dr. Arunam Patel, working as an editor at HUMC. My topic is knowledge of snakes and snake bite management practices among residents of Kolar. This is my ICMR topic, which I done with the help of Dr. Demedcon sir, with the help of Department of Forensic Medicine and Toxicology. Through this format, I will be delivering my content. Introduction. Why snake bite? According to WHO data, half of world mortality by snake bite is reported from India. Snakes are reptiles that bite for defense, for hunting. India reports 20% of snake bite deaths annually. WHO has declared snake bite as a neglected tropical disease in 2017. India's healthcare challenges is there is no shortage of antivenom, but there is an inefficient distribution causes delays in reaching antivenom to such remote areas. What we know there are two types of snakes. There is one venomous and non-venomous snake. Venomous snakes are that which release venom during bite. There are snake bite that is there is no release of venom. That is called as dry bite. Such bites have lacerations or some prick-like. And due to such type of thing, the people got panicked and there are chances the people can go for death also. After doing our study, this survey, we saw people having knowledge about dry bites were just 7.33%. Believed all snake bites were deadly were 65.33%. Aware that some snakes are non-venomous were 92.66%. Okay. Such same research was done by Ishan Pathak et al. At Belgavi, observed 38% could identify between the venomous and non-venomous snakes. What are the limitations? People have limited awareness of snake species and the fact that not all snake bites are fatal. There was many myths about snake bite versus yet. Many people die from fear, not venom, due to such misbeliefs. Our case study was done in Kolar. So Kolar is an area where the major occupation of the population is agriculture, sericulture, dairy farming. So these people are more prone to such activities of snake bite and management. They are more prone to such exposure. Our study objectives were assessing knowledge of snakes and snake bite management, evaluate beliefs and practices surrounding snake bite management in Kolar. Our materials and methods. Our study used question-based approach to assess knowledge and practices related to snake bite. We selected participants from 4 villages, 3 degree college and 5 PSC to ensure we capture data from wide. Our main area of focus were Malur, Srinivaspura, Mulbagan and Main Mangal. We divided the population into two, common people and healthcare workers. In common people we choose farmer, students, teachers, and healthcare worker we choose ASHA worker, ambulance driver, medical officers, which gave a total of 300 participants. Data was collected through direct interviews using Google Forms, which allowed us to standardize our approach and ensure consistency in the information. And further results we got. Our sample consisted of 300 participants with 59.6 males and 40.3% females. The majority of participants were aged between 31 to 40 years. Most of the participants had significant exposure to snake due to such occupations in the fields. On discussing, we got this. High percent of people who had witnessed the snake's bite and are alive, that is 94%. 92.6 knew that some snakes are non-venomous. Only 7.3 were aware of the concept of dry bite. It is worth to note that all the participants we conducted were knowing that taking that patient or snake bite patient to hospital is 100% safe. Discussion. The study revealed significant gaps in the knowledge of snake bite management, particularly among common people in Kolar. As we know, Kolar border is shared by Andhra and Tamil Nadu. So there are 3 different cultural beliefs which are practices in this Kolar region. So some myths were like people think that the snake which is making more hissing sound are more dangerous. As there are if there is a bite by venomous snakes, there are chances of bitterness in the taste. So healthcare management also, there was so much gap of lack of information in between the healthcare management also. Only 40.6% of people were aware of the concept of dry bite and just 8.66 had attended any formal training on snake bite management. It is to know that Government of India has made clear restrictions standardized that we should not use any tourniquet, we should not suck that wound. There should be clear-cut use of loose tourniquet above the wound, which would be helpful in the first aid. Implications for public health. Targeted education and training programs should be made. Community engagement and outreach can be done, including CNEs, workshops, and doing further studies for such prone area. Adaptation of health services should be done to improving healthcare infrastructures and including making this ASU available in such remote places which are more prone. And there should be policy development should be done for such prone area to reduce such type of conclusions. Improving community health outcomes, reducing snake bite related morbidity and mortality, fostering a safer environment in district Kolar district. So after doing this, we could make the people who are on the first in the farm, at least they should know what is the first aid management, and the people who are working in healthcare institute should know, they should know how we are approaching towards snake bite management patients. My references was this. Thank you. Future or scope of my study is to publish this paper in further journal. Thank you.
Did you agree your question?
Ma'am, I have researched different papers which are done in different districts of India, like Palghar, Belgavi, and different states of Uttar Pradesh. Through this, we had directed our questions.
And how did you decide the number of participants?
It was a random study. We choose around 400 populations which we have selected, and out of 400 people who have given consent, we choose them, and we got a ratio of, because our study duration was from November 2022 to October 2023. During this time, we had time for submission of ICMR abstract, and that period, whatever population is got, we choose that.
What's the method of the statistical analysis? How did you analyze your data?
We use EPI software. You used using put in the Excel and use EPI software.
What is the software method? Analysis method.
Analysis, ma'am, we compared different people, like what are the perceptions, what are the beliefs, and what are the above 18 of age and compare different data using different papers.
Did you do it in the hospital or did you go to each village and ask these questions?
Ma'am, first we done our study in hospital. Then first we went to Mool Bagar where my district rural hospital is there where I was working. So we spent there some time. Then we approached to three districts, Srinivasapura and Maluri went, and we spent 2-3 like I used to go 2-3 days and collect data. We had a questionnaire in this Kannada language. We used to ask to the farmers and which people we are involved in dairy farming, floriculture, such that I'm going to do sample.
Thank you, sir. Thank you, everyone. It was a wonderful event. Now I request some time to reveal the winners. I now request the judges to announce the winners.
At the outset, I congratulate all the participants for their effort and taking out their time, and the papers were good. The preparation was also good. But we have to classify, I mean, as per the directions of the organizers, the first three participants, I mean, the best ones we have just inked it, and then out of the third place goes to the oral presentation number 3, Shubha SM. And the second place goes to oral presentation number 4, Dhanvi DM. The first place goes to oral presentation number 2, Piyush Pandey. Thank you.
I now request the judges to please provide the participation certificates to the participants. Judges, please come to the stage. The first participant, Kusuma N. The second participant, Piyush Pandey. The third participant, Shubha SM. The fourth participant, Dhanvin BM. Dr. Aditya Sridhara. Nitin Gowda. Sakshi Bora. Sagar. Next, Aditi V. Anupama Narayana. Arunabh Pathak. Dr. Arunabh Pathak.
May I now request Dr. Vinita Ma'am, Vice Principal, to give away the mementos to the judges.
I now request the judges of the poster presentation to announce the winners.
All the participants from poster competition are here, right? Okay. Third place goes to Nihal. Okay, second place. Jennifer. And first place, yes. Rachel. Yeah, you.
Now I request the judges of the poster presentation to come on the stage and give the participation certificates. First participant, Pratyusha Prasad. Pratyusha Prasad. Second, Jayanshu Goyal. Third participant, Shruti Saranya. Shruti Saranya. Reason Gupta. Vedant Narula. Vedant Narula. Next, Jennifer Stephens. Varshita Shetty. Bhavika K. Nihal Pediakal. Arkadatta Das. Neghna Raj. Oshin. Can anyone connect the participation certificate for Oshin?
मैं कलेक्ट कर दूं?
Now I request Vinuta ma'am to give the mementos for the judges of poster presentation. I request Sudharati madam also come on the dais. All the participants, organizing members Ekta, Malay Ranjan Das, and all the judges and Vinuta ma'am, we want you for the photograph.
Background ಅದೇ ಇರಲಿ. ಹಾಗೆ ಬರೋದು ಹಾಗೆ ಇರು. ಆಯ್ತು ಬರತ್ ಆಯ್ತು.
Thank you everyone.
ವಾಚ್ಮ್ಯಾನ್ಗಳು ಅಲ್ಲೇ ಇರ್ತಾರೆ, ತೊಂದರೆ ಇಲ್ಲ. ಪೆಂಡಲ್ ಹಾಕ್ಬಿಟ್ಟು ಟಾರ್ಪಲ್ ಹಾಕ್ಬಿಟ್ಟು ಪವರ್ ತೆಗೆದುಬಿಡು, ಒಬ್ಬಳೆ ಹೆಂಗೆ ಆನ್ ಮಾಡ್ಕೋಬೋದು, ಏನು ಕೊಟ್ಟುಬಿಟ್ಟು ಇದನ್ನು ನಿಲ್ಲಿಸಿ. ಹಾಂ ಹಂಗೆ ಮಾಡಿ ಕೀನ ತೆಗೆದು ಅರ್ಧ ಏನು ಬೇಡ, ನಾನು ಫೋನ್ ಮಾಡ್ತೀನಿ. ಸಾಯಂಕಾಲ ನಿಲ್ಸ್ಕೊಂಡು ಊರಿಗೆ ಅವ್ನು ಚೆಕ್ಕೆ ನೀನು ಫೋನ್ ಮಾಡಿ, ನಾನು ಫೋನ್ ತೆಗಿತೇನೆ. ನಂಬರ್ ಕೊಡಲಾ? ಚೆಕ್ಕೆ ಬೇಕಾ? ನೀನು ಮಾಡು. ಈಗ ಮಂಜನ್ ಕಳ್ಸಿದ್ದು ಎಲ್ಲ ಪಾರ್ಟಿ ಕೇಳಿದ್ದು ಅಪ್ಪ ನಾನಪ್ಪೋ ಮಂಜುನಪ್ಪೋ ನೀವು ರಾಜು ಹತ್ರ ಬಂದರೆ ಸುರಿಯಾತ್ರಿ ಇವಾಗ ಈಗ ಹೆಂಗೆ ಸಿಟಿ ನೀವು ಫೋನೇ ತೆಗಿತಾ ಇಲ್ಲ, ನನ್ನ ಹತ್ರ ಗೊತ್ತಿಲ್ಲ. ಈಗ ರಾಜು ಹತ್ರ ಇದ್ದೀನಿ. ಹಾಂ ಮಿಸ್ ಮಾಡಬೇಡ ಪ್ಲೀಸ್. ಏನಾಗಿದೆ ಗೊತ್ತಾ, ಅವ್ರು ತುಂಬ ನಂಬ್ಕೊಂಡ್ಬಿಡ್ತಾರೆ. ಇನ್ನೂ ಗೊತ್ತು ಪಾರ್ಟಿ ಹೆಂಗೆ ಅಂದ್ಬಿಟ್ಟು ಆಗುತ್ತೆ. ಹಾಂ 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 ನಾನು ಫೋನ್ ಮಾಡ್ಕೊ, ನಾನೆಲ್ಲ ಇದನ್ನೆಲ್ಲಿದೆ, ನಾನು ಎಲ್ಲ ತಗೊಳ್ತೀನಿ. ಹಾಂ ಓಕೆ ನಾನು ಫುಲ್ ಖರಾಬ್ ಹೋಗು ಅಣ್ಣ. ಊರ ಹತ್ರ ಪ್ರಾಮಿಸ್ ಒಂದು ಬಿಟ್ಬಿಟ್ಟು ಹೋಗ್ಬಿಡ್ತಾ ಇದ್ದೇನೆ ನಾನು. ಅವ್ನು ನೋಡ್ಕೊಳ್ಳೋ ಎಷ್ಟು ಮಾತು, 50 ರೂಪಾಯಿ ಕೆಲಸ ಆಗೋಗ್ತಾ ಇದ್ದಲ್ಲ. ಇಲ್ಲ ನಾನು ಏನು ಈಗ ನನಗೆ ಏನಿಲ್ಲ, ಎಷ್ಟೇ ದುಡ್ಡು ನನಗೇನು ಗೊತ್ತು ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತಾರಲ್ಲ, ನನ್ನ ಬ್ಯಾಟ್ರಿ ಚಾರ್ಜ್ ಹಾಕ್ಬೋದು, ನನ್ನ ಬ್ಯಾಟ್ರಿಗೂ ಚಾರ್ಜ್ ಹಾಕ್ಬೋದು. ಫಾಸ್ಟ್ ಮಾಡ್ಕೊಂಡು ಆಫ್ ಮಾಡಬೇಕಾ? ಆ ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ ಕೊಟ್ಕೊಂಡಿದೆಯಲ್ಲ, ಸ್ವಲ್ಪ ಆಫ್ ಮಾಡಲಿಲ್ಲ. ಬೇಡಪ್ಪ, ಹಾಗೆ ಬೇಡ. ಅಲ್ಲ ನೀನು ಸ್ಟಿಲ್ ಅಲ್ಲಿ ಫಾಸಲ್ಲಿ ಇರ್ತಾರೆ. ಲ್ಯಾಪ್ಟಾಪ್ ಕೊಟ್ಬಿಡಿ ಗಣೇಶ್, ಅದು ಬಂದ್ಬಿಟ್ಟು ಅಲ್ಲೇ ಕಾಲೇಜ್ ಬಿಡಿ ಅವ್ರಿಗೆ ಬೇಜಾರಾಗ್ಬಿಟ್ಟಿದೆ. ನಾನು ಎಷ್ಟು ಸತಿ ಹೇಳಿದೆ ಗೊತ್ತಿಲ್ಲ, ಬೇಡ ನಾವು ಹೊರಗಡೆ ಹಾಕ್ತಿಲ್ಲ, ಪವರ್ ಹಾಕ್ತಿಲ್ಲ, ನಾನು ಸಾಲದಲ್ಲಿ ಇಟ್ಕೊಳ್ಳೋದು ಬೇಡ ನೀನು ಹೇಳ್ಬೇಕಾಗಿತ್ತು
ಇಲ್ಲ ಮೈಸೂರು ಸರ್ ನಾವು ಹುಡುಗರು ಕಾವಲು ಬೇರೆ ಕೂಡ ಹೋಗ್ಬಿಟ್ಟು
ಏನು ಹೇಳೋದಪ್ಪ ಪವನ ಬಾಯಿಲ್ಲ ಆ ಮೇಡಮ್ ತಾನೆ ಕಾವಲಿತ್ತು ಅಂತೇಳಿ
ಅಲ್ಲ
ಹೌದು ನಿಜ ಒಂದೇ ಥರ ಸರಿ ಹಾಂ
ಕಾವಲು ಇಕ್ಕಲ್ಲ ಇಕ್ಬಿಟ್ಟಿದ್ರು ಅವನು ತಪ್ಪಿಸಿಸ್ಕೊಂಡಿದ್ದ
ನೀವು ಇಷ್ಟದಾಗಿ ಮಾಡಿಬಿಟ್ಟೆ ಹೋಗ್ಬೋದು ನಾನೇನು ಹೇಳಿದೆ ಗೊತ್ತಾ ಬಸ್ಸಲ್ಲಿ ಬರ್ತಾ ಇದ್ದೆ ಮೇಡಮ್ ಆಯ್ತಾ
ಹ್ಞೂ ನಾನು ಹಂಗೆ ಹೇಳಿದೆ ಮೇಡಮ್ ಟೆಕ್ನಿಷಿಯನ್
ನಾನು ಇರೋ ವಿಚಾರ ಹೇಳಿದೆ ಅವ್ರು ಬಂದರೆ ತಾನೇ ಇದು ಮಾಡೋದು
ಟೆಕ್ನಿಷಿಯನ್ ಮಾಡಿದ್ರೆ ಏನಿರ್ಬೇಕು ಅವ್ರು ಬರ್ಬೇಕು ನೀವಿರ್ಬೇಕು
ಬ್ಯಾಟ್ರಿ ಕೈ ಕೊಟ್ಬಿಟ್ರೆ ಕ್ಯಾಮ್ರಾ ತಂದು ಅಲ್ಲಿ ಬಂದ್ಬಿಡ್ತೀನಿ ಎಂತಕ್ಕೆ ಇದೇ ಮೇಲೆ ಕೊಡ್ಬಿಡಿ ಏನು ಮಾಡಿ
ಆದ್ರೂ ಕೊಡ್ಬೇಕಲ್ಲ
ಯಾವ್ದಕ್ಕೆ
ಖಾಲಿ ಆಯ್ತಲ್ಲ ಕಾಪಿ
ಅದೇನು ಸ್ಟಾಪ್ ಆಗ್ಬಿಡ್ತದೆ ಎಲ್ಲದಕ್ಕೂ
ಅರ್ಜುನ್ ಥರ
ಕಾಲೇಜ್ಗೆ ಐಮನೆ ಇಟ್ಟು
ನಾಳೆ ಮನೆ
ಕಂಪ್ಲೀಟ್ ಕಾಲೇಜ್ ಇಲ್ಲ ತಗೊಂಡ್ಬಿಡ್ತೇನೆ ನಾನು ಚಾರ್ಜರ್ ಮೊಬೈಲ್ ಚಾರ್ಜರ್ ಹಾಕಿದ್ರೆ ಸರ್ ಹೋಗ್ತದೆ
ಇದಕ್ಕೆ ಪವರ್ ಹೆಂಗೆ
ಅಲ್ಲ ಅಲ್ಲೇ ಅದಕ್ಕೆ ಹಾಕಿ
ಒಂದಕ್ಕೆ ಹಾಕೊಂಡ್ರೆ ಸರ್ ಅಲ್ಲ 2 ಬ್ಯಾಟ್ರಿ ಇರುತ್ತೆ ನಮ್ಮ ಮನೆಗೆ
ಎತ್ಕೊಂಬಂದು ಟೆನ್ಷನ್ ಆಮೇಲೆ
ನಾಳೆ ಎಷ್ಟೊತ್ತು
ಎಲ್ಲ ಕೆಲಸ ನನಗೇನು ನೀನೇ ನೋಡ್ತಾ ಇದ್ದೀರ
ನನಗೆ ಗೊತ್ತಿರೋ ಮಾತ್ರ ಎಲ್ಲರೂ ಅವಶ್ಯಕತೆ ಇಲ್ಲ ಇನ್ನು ಅಷ್ಟೇ
ತಿನ್ನೋರು ನೀನು ಯಾಕೋ
ಅಲ್ಲ ಇವಾಗ ನಾವು ನಾಳೆ ಬೇಕು
ಇಲ್ಲೇನು ಇರ್ತಾನ ಎಲ್ಲರೂ ಓನಾಡಿರುತ್ತ ಇಲ್ಲಿಂದ ಶ್ರೀಹಣ್ಣ ಫೋನ್ ಹೋಗ್ತಾರೆ ಆಯಪ್ಪನ
ಅವರು ಪಾಪಡ ಲಾಸ್ಟಿಗೆ ಇರ್ತಾರೆ ಲಾಸ್ಟ್ ಮಾಡಿದ್ರೆ
ಈಗ ನೋಡಿ ಹಿಂದೆ ನೋಡು
ಅವಾಗ ನರ್ಸಿಂಗ್ ಅವ್ರು ಕರ್ಕೊಂಡು ಕೂರ್ಸಿದ್ದು
ಗೊತ್ತು
ಕನೆಕ್ಟ್ ಇರಲಿ ಅಂತ
ಏನು ಗೊತ್ತಾ ಇದೆ ನಮ್ಮ ಪ್ರೊಸೀಜರು
ಬೇರೆ ಕಾಲೇಜಿನವರೆಲ್ಲ ಬರ್ತಾರಲ್ಲ
ಈಗ ನಿನ್ನ ಈಗ ಸೇರಿಸ್ತೀಯಲ್ಲ ನಮ್ಮ ಕಾಲೇಜಲ್ಲಿ ರಿಪ್ಲೇಸ್ಮೆಂಟ್ ಇದೆ ಅದು ಇದು ಅಂತೆಲ್ಲ ತುಂಬಿಕೊಡ್ತಾರೆ ಏನಿರಲ್ಲ ನೀವು ಲಾಸ್ಟಾಗಿ ಗೊತ್ತಾಗ್ತದೆ ಎಷ್ಟು ನಿಜಮ್ಮ ಎಂತ
80% ಹುಡುಗರು ಅವ್ರವ್ರ ಲೋಕಲ್ ಲ್ಯಾಂಗ್ವೇಜ್ ಮಾತಾಡ್ಕೊಂಡು ಎಲ್ಲ ಅವ್ರವ್ರ ಲೋಕಲ್ ಅವ್ರವ್ರ ಟೀಮ್ ಇದೆ
ಸಾಯಂಕಾಲ ನೋಡ್ಬೇಕು ನೀವು ಖುಷಿಯಾಗಿ ಹೋಗ್ತೀಯ ಭಯಂಕರ ಆಡ್ತಾರೆ
ಬಹಳ ಖುಷಿಯಾಗಿ ಕರ್ಕೊಂಡು ಹೋಗ್ತೀನಿ
ಹಂಗಲ್ಲ ನೀನು ಹೇಳ್ತಾ ಇರೋದು ಹೋಗ್ಬಿಟ್ಟಾಗ ನಿಮ್ಮ ಥರ ಇದ್ದಾರೆ
ರೆಡಿ ಮಾಡ್ತಾ ಇರೋದು ಏನಿಲ್ಲ ಮ್ಯೂಸಿಕಲ್ ರೈಟ್
ಚೆನ್ನಾಗಿ ಆಡೋದು ಮೇಡಮ್ ಆಗ
ಚೆನ್ನಾಗಿ ಮ್ಯೂಸಿಕಲ್ ರೈಟ್
ನೀನು ಹೇಳ್ತದ ನಿಮಗೆ
ಮುಂಜಾನೆ
ಫುಲ್ ಹುಡುಗಿ ಸಿಂಗಿಂಗ್ ಮಾಡೋದು ಪ್ರಾಕ್ಟೀಸ್ ಇಲ್ಲಮ್ಮ ಇಬ್ಬರು ಅಷ್ಟೇ ಹುಡುಗ
ಅವರ ಮುಂದುಗಡೆ
ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಿ
ಅವರ
ಏನು
ಸೂಪರ್ ಆ ಹುಡುಗಿ ಜನ ಆ ಹುಡುಗನಿಗೆ
ಹೆಂಗಿದೆ ಅಂದರೆ ಎಲ್ಲ ಗಾಡಿ ನೋಡಿ ಎಜುಕೇಷನು ಇದೆ ಇದು ಇದೆ
ಬೆಣ್ಣೆನಲ್ಲಿ ಕೂದಲು ತೆಗೆದಾಗ
ಸಂಗೀತ ಕಲ್ತ್ಬಿಟ್ರೆ ಆಸ್ತಿ ಪೀಸ್ ಪಾಯಿಂಟ್ ಆಗಿರ್ತಾರೆ ಅವರು ನೆನಪಿಟ್ಟು
ಅಂದರೆ ಬೇಕಿಲ್ಲ
ಎಲ್ರಿಗೂ
ಸರಸ್ವತಿ
ಎಲ್ಲ ಕತೆ ಓ ನೋಡಪ್ಪ ಈಗ ನೋಡು ಈ ಕೂಲಿಯವ್ರು ಬರ್ತಾರೆ ತೋಡುತ್ತಾ ಚಡ್ಡಿ ಗ್ಲಾಸ್ ಕೊಡೋದು ಫಸ್ಟ್ ಹೇಳ್ತೀನಿ ಕೇಳ ನಿಮ್ಗೆ ಗೊತ್ತಿರ್ತದೆ ಫಸ್ಟ್ ಹಣ ದಿನಕ್ಕೆ ಇಷ್ಟು ಕೊಟ್ಬಿಡು ಅಂತ ಹೇಳ್ತಾರೆ ಬಂದ ಹಣ ಯಾರಲ್ಲ ಹಣ ಒಪ್ಪಂದ ಕೊಡೋದು ನೀನು ಹಾಗಂತ
ಅಲ್ಲ ರೈಟ್ ಇಲ್ಲೇ
ಏನಕ್ಕೆ ರಾಜ್ಕುಮಾರ್ ಬಂಗಾರಪೇಟೆ ನಥಿಂಗ್ ಬಟ್ ಬ್ಯಾಂಗ್ಳೂರ್ ಟು ಕೇರ್ ಫ್ರಮ್ ಹಂಗೆ ಅದು ಬೆಂಗಳೂರು ಲೆಕ್ಕ ಇದು ಬಂಗಾರಪೇಟೆ ಕೋಲಾರ ಲೆಕ್ಕನೇ ಇದಕ್ಕೆ ಹಿಂಗೆ ಅಂತೀಯ 40 ಕಿಲೋಮೀಟ್ರ್ ನಾನು ಪಕ್ಕದಲ್ಲೇ ಇದ್ದಂಗೆ ಬಂದ್ಬಿಡ್ತೀನಿ ಗೊತ್ತು ವರ್ಷ ಇವಾಗ ನಿಂತ್ಕೊಂಡು ಹೋಗ್ತೀನಿ ಹಂಗಲ್ಲ ಇನ್ಕಮ್ ಪ್ರಶ್ನೆ ಅಲ್ಲ ಅದೆಲ್ಲ ಡಿಸ್ಟೆನ್ಸ್ ಅಲ್ಲ
ಎಲ್ಲ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಇಲ್ಲ ಇನ್ನೊಂದು 5 ವರ್ಷಕ್ಕೆ ಕೆ ಜಿ ಎಫ್ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗುತ್ತೆ ನೋಡು ಎಲ್ಲಿಗೋ ಕಿತ್ಕೊಂಡು ಹೋಗುತ್ತೆ ಕೆ ಜಿ ಎಫ್ ಸ್ಮಾರ್ಟ್ ಸಿಟಿ ಆಗ್ತದೆ ಸರ್ ಇಂಡಸ್ಟ್ರಿಯಲ್ ಹಬ್ಬ ಸ್ಮಾರ್ಟ್ ಸಿಟಿ ಹೈವೇ ಬೇರೆ ಐತೆ ಮೊನ್ನೆ DC ಪ್ರೋಗ್ರಾಮ್ ಹೋಗಿದ್ದೆ ವಿಷನ್ 2030 ಕೊಟ್ಟಿರೋ ಪ್ಲಾನ್ ಪ್ರಕಾರ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗ್ಬಿಟ್ರೆ ಮಿನಿ ಬೆಂಗಳೂರಿಗೆ ಜೋರಾಗಿ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಆಗುತ್ತೆ ಎಲ್ಲ
ಎಲ್ಲಾಗಿ ನಮ್ಮ ಕೋಲಾರ ನಮ್ಮ ನರಸಾಪುರ ಇದು ಕೋಲಾರ ಈ ಕಡೆ
ನಮ್ದು ಇಂಡಸ್ಟ್ರಿಯಲ್ ಹಬ್ಬ ಕೆ ಜಿ ಎಫ್ ಅಂತ ಹೈವೇ
ನಮ್ಮ ನರಸಾಪುರದ ಕೇಳಿ
ಕೆ ಜಿ ಎಫ್ ಆಗೋದು ಬಂಗಾರ ಹೈವೇ
ಏನು ಜನ ಮಿಸ್ ಮಾಡ
ಅಂದರೆ ಈ ಕಾಲೇಜ್ ಬೇರೆ ಕಾಲೇಜುಗಳೆಲ್ಲ ಬಿಡ್ತಾರಲ್ಲ.
ಅವರೆಲ್ಲ ಜವಾಬ್ದಾರಿ ತಗೊಳ್ಳಲ್ಲ, ರೆವಿನ್ಯೂ ಅವರೆಲ್ಲ ಅದೆಲ್ಲ ಲೆಕ್ಕಕ್ಕೆ ಬರಲ್ಲ, ಎಲ್ಲೂ ಇದೆಯಾ ಹಂಗೆ ಕಳಿಸಿದ್ದಾರೆ ರಾಕೆಲ್ಲ ಫೋನ್ ಮಾಡಿ ಫೋನ್ ಮೆಕ್ಯಾನಿಕ್ ಬರ್ತಾನೋ ನಿಮ್ಗೆ ಯಾವ ಕೊಡೋ ನಿಮ್ಗೆ ಕೇಳೋ ರಾತ್ರಿ 11 ಗಂಟೆಗೆ ಮಾಡಿದೆ, ಬೆಳಿಗ್ಗೆ 4:30 ಮಾಡಿದೆ, 5:30 ಅವನು ನಾನು ಕರ್ಕೊಂಡು ಹೋಗೋಣ ಭಯನೇ ಬಿಡೋಣ ಇಂಚು ಹೋಗೋಣ 5:30 ಕರೆಕ್ಟಾಗಿ ಪವನ್ ಅಲ್ಲ ಪವನ ಕರೆಕ್ಟಾಗಿ ನಾನು ಅಲ್ಲಿ ಕರ್ಕೊಂಡು ಬಂದಿದ್ದೆ ಮುಸ್ತಾನ್ ಹತ್ರ ಹಂಗೆ ಬಂದು ಹಂಗೆ ಅವ್ನು 2 ನಿಮಿಷ ಮಾಡಿದ್ದೆ. ನನಗೂ ಗೊತ್ತಾಗ ಮಾಡೋದು ಇವ್ರು ಮಾಡೋಕ್ತಾನೆ, ನನಗೆ ನನ್ನ ಟೈಮ್ ಸರಿ ಇಲ್ಲ, ನಂಗೆ ಏನು ಮುಟ್ಟ ನಾನು ಏನು ಮುಟ್ಟ ಹೋಗೋದು ಏನಾರು ಹೋಗ್ತದೆ. ನನಗೆ ನೋಡೋ ಟೈಮ್ ಚೆನ್ನಾಗಿತ್ತು, ಅವ್ರು ಫೋನ್ ಮಾಡಿದ್ರು, ಅವಾಗ ತಾನೇ ಸೌಂಡ್ ಆಫ್ ಆಗಿತ್ತು, ಸೌಂಡ್ ಇದ್ದಿದ್ರೆ ಮಾಡೋಕ್ಕಾಗ